Presentation is entitled Randomized Comparison of Straight versus Articulating Instruments for Single Incision Laparoscopy, and Dr. Santos will be presenting.
Hello, and thank you for the opportunity to present. I will be presenting a combined study that we did as well, looking at the effect of both training and instrument type on performance in single incision laparoscopy using a simulated setting. I have only the relevant disclosures shown. Single incision laparoscopy has emerged as a potential alternative technique to standard laparoscopic techniques due to the potential advantages listed here. However, there are current technical issues that exist with a single incision technique. We and other groups have previously shown in a simulator setting that single incision techniques are more technically challenging compared to laparoscopic techniques. However, we don't know anything about the learning curve for single incision. To find out more about that, and also to determine whether SIL-specific training on a simulator and the use of dynamic articulating instruments could help, this study was performed. We looked at two tasks from the fundamentals of laparoscopic surgery, peg transfer and pattern cutting, which we have previously shown have good discrimination between experienced and inexperienced subjects for single incision. These are scored using standardized metrics reflecting time and accuracy. To estimate the learning curve, we used the previous method of plotting score by trial number and determining a learning plateau, which represents the theoretical maximum score with an infinite number of repetitions. We also looked at the learning rate, which we defined as the number of trials needed to reach 95% of that plateau. There were four groups that we were interested in studying: the gold standard laparoscopic technique using straight instruments, as well as three different instrument configurations for single incision: static articulating instruments, straighter instruments, and dynamic articulating instruments. These were divided into two separate studies, a training study and an instrument study. We recruited novice first and second year medical students and were randomized to one of two groups within each study. Subjects underwent baseline testing on both tasks. The subjects in the first study underwent testing on both lap and single incision techniques. These subjects then completed a period of training consisting of 4 sessions, approximately an hour each, during which they performed repetitions of the tasks. After the training, we again post-tested these subjects. Again, the first training study, they were tested on both techniques. The results of the first training study show that for laparoscopic tasks, both lap-trained and single-incision-trained subjects improved consistently over time. There was no difference in the level of improvement between the subjects. However, for single-incision tasks, we can see that single-incision-trained subjects improved significantly more than the lap-trained only subjects. As far as score by instrument type for PEG and circle, on the left we can see that for PEG, laparoscopic technique outperformed all single incision techniques. There was no difference among the single incision groups. Similarly for circle, lap was the top scoring technique. There was no difference compared to static articulating, however. The p-value for this was very close, 0.07. In terms of the learning curve for PEG, according to instrument type, we can see here laparoscopic was the top line. And again, there was no difference compared to static articulating. However, it did beat all the other single incision groups. And there were no differences among the single incision groups. As far as the learning rate, laparoscopic clearly had a shorter learning rate compared to the other single incision groups. For circle, which is a harder task, you can see that the scores all dropped. However, we still see that laparoscopic was able to outperform all the other techniques. It was also associated with a faster learning rate, with the exception of single incision using straight instruments. Limitations of this study included the fact that we only looked at novices in a controlled laboratory setting, as well as our choice of trocar, ports, and instruments are one particular choice, but there are others. We had a small number of participants, and it's possible that we also looked at them too early in their learning curve. In conclusion, we feel that simulator training for single incision appears to show benefits. Laparoscopic training only may be suboptimal compared to single incision training in improving single incision techniques. There also seemed to be a persistent technical performance gap for single incision compared to laparoscopic over the period of the study. And the learning curve for single incision techniques appears to be longer compared to lap. Finally, we showed no clear advantage for articulating versus straight instruments for single incision, either in peak performance or in the learning rate. I'd like to thank my mentors and also the people from the lab who helped finish this study. Thank you.
This paper is now open for discussion.
Dimitri Olenek of Omaha, Nebraska. I enjoyed your talk very much, and I think you've shown us what we've all known, and that is it is a lot more difficult to do single incision surgery. Clearly, there remains a technology gap. I have two questions for you. Number one, do you think that the articulating instruments did not provide benefit because you used only certain kind of articulating instrument, whether articulating instruments that you would love to use but couldn't get your hands on? Do you think those would have made a difference? And my second question is, do you think a robotic platform, such as what the Da Vinci is coming up, would negate this difference or not? Thank you.
Thank you. Those are excellent questions. I think that one of the limitations potentially with the articulating instruments is the level of control and additional things that the surgeon has to manage motor skill-wise. And I think there probably is a theoretical limit to that, and I'm not sure that different kinds of articulating instruments may help, although perhaps ergonomically, if we can improve these instruments in the interface, it's possible that we may eventually match performance. As far as your second question, I think robotic platforms have a tremendous promise in terms of simplifying the interface for the surgeon, being able to cross arms, being able to direct the machine to control the arms in a more natural configuration for the surgeon. I think there's definitely potential there.
Ronnie Clements, Nashville, Tennessee. Congratulations on a well-conducted study. I admire your looking into this idea. I will have one question about your methodology I'd like you to consider. You looked at the FLS task. That test was designed for a straight instrument, so you may have a self-predicting outcome that the straight laparoscopic instruments did indeed show better training improvement with that. I would ask you to have you thought about a different task to perform that would really maximize the effect of an articulated instrument. Have you considered that as a possible variable here?
That's a good point, and this was something that we thought about when we were first thinking about study design, and I think it's important to remember that the FLS tasks really were not designed with any specific platform involved. They really were designed to simulate tasks that had to be performed no matter what operation and technique you were doing. So things like moving one object to another side, being able to suture. I think regardless of the instruments that you're using, I think those are fundamental enough tasks that we felt that it would not be appropriate to change the task specifically for this comparison.
Question back.
Yoav Mintz from Hadassah, Israel. I enjoyed the presentation. However, in a single incision surgery, one of the form factors are that you have to have a good vision from a 30-degree laparoscope, which is inserted in parallel to your instruments. It wasn't clear from your pictures, did you use an actual laparoscope or you use the same simulators? Because what I can think is that you didn't have an advantage over articulating instruments because you didn't have to fight with the laparoscope and achieving the right field of view.
Yes, so that's an excellent question, and I didn't go into that for the sake of time. However, I will tell you that for the testing, baseline and post-testing, we tried to recreate as realistic technique as most surgeons out there would probably do. So we used a 5mm 30-degree laparoscope with a 90-degree light cord adapter to make that more low profile. And for the practice sessions themselves, actually we used only the internal camera. So I think we used an approximation of the real thing, but probably if we had looked at training with the real camera as well, we probably would have seen even lower scores.
Final question?
Hi, Shannon Fraser from Montreal. I noticed in your learning plateaus were quite different between the sills versus the laparoscopic. Could you comment on whether you think that's a function of just that you're having novices, or do you think if with additional training that plateau would move, because we see that with our the FLS tasks?
Yeah, I think that's a good point. I think there probably would be some small improvement. However, if you look at the level improvement compared at the 95th percentile compared to the theoretical plateau, there really is not much. It's only about 2%. So, granted, I think that you could probably do better if you had better, perhaps instruction. Instruction for these participants was standardized, and so I think potentially with different methods of instruction, proctoring, you probably could do a little bit better.
Thank you very much.